Good day. Okay, nurses. This presentation is about muscle relaxants. This is a very diverse group of drugs, but the outcomes are pretty much the same for each drug. You have reduced activity in the muscles, and that will reduce spasms and reduce the pain associated with spasms. So spasticity typically results from damage to the muscle. Spasticity or a spasm is a sustained and constant contraction of the muscle. You get these sometimes violent and very painful, completely involuntary contractions of the muscle. They're caused by trauma to the muscle. That trauma can be due to a blow to the muscle. It can be due to overuse of the muscle. It can be due to overstretching of the muscle. Problems with joints, if you tweak a joint and you put eccentric stress on the tendon and the muscle as well, and or the muscle. If you get a tear in the tendon, the injured area will flood the sensory nerves to the muscle, and that sensory input will then go to the spinal cord, and the muscle will respond with these rather intense contractions. And those intense contractions, as a result of these extensive sensory inputs, those essentially result in spasms. Pain from the muscles will then result from lactic acid buildup in the muscle. That will cause more sensory information to be sent back to the spinal cord. That will usually elicit a compensatory increased contraction of the muscle. And so you have a bit of a vicious cycle. As the muscle gets more damaged, it hurts more. As it hurts more, it spasms more. So muscle relaxants, excuse me, will treat both permanent and temporary neuronal damage to the muscle. They will essentially interfere with this cycle of pain and spasm, pain and spasm. Muscle relaxants fall into two groups, whether they work in the central nervous system or whether they work directly in the muscle. So your centrally acting skeletal muscle relaxants include baclofen, carisoprodol, chlorzonaxone, cyclobenzaprine, methylcarbamol, orphenadrine, and tizanidine. And these go by various trade names that you may know them by. So Flexeril is a common name for cyclobenzaprine. Cyclobenzaprine is probably the one that gets used the most. Carisoprodol is called Soma. Baclofen is available in a generic, so it tends to just be called baclofen. But if it is available in a trade name drug, it is Lioresal. And then tizanidine is called Zanaflex. Tizanidine is used a fair amount in athletes because it has a short half-life. Morphenedrine is not used that much. The direct-acting skeletal muscle relaxants include your botulinum toxins, type A and B. That's a mistake here. That should be type B. That goes by the trade name of Myoblock. Type A is the Botox that's also used for cosmetics. These are also used for migraines. They're not first line, but if you have a migraine that refuses standard treatments, this will usually be used. Dantrolene is a drug all of you have to be familiar with. Dantrolene is used if the anesthesia causes malignant hyperthermia. Dantrolene is a treatment for that. So every single unit, surgical unit, whatever unit that uses anesthesia or uses succinylcholine, we use dantrolene. And then incobotulinum toxin A, relatively newer drug, that's Xamarin. This is a very diverse group of drugs when it comes to their mechanisms. It's difficult to pin down one particular mechanism. There are several. So if I take you to the next slide, I'm going to go back and forth between this slide and the next slide. We can see that the motor neuron has an upper motor neuron with which it synapses. This would be your lower motor neuron. The lower motor neuron connects essentially from the motor cortex to these upper motor neurons, and then it synapses to the lower motor neuron here, and then the lower motor neuron releases acetylcholine at the motor end plate here. Now, there are also inhibitory interneurons. These release GABA, gamma-aminobutyric acid. There are GABA A and GABA B GABAergic receptors, both on the upper motor neuron and here on the lower motor neuron. Some of those drugs that are benzodiazepines target the GABA A receptor. All benzodiazepines target the GABA A receptor. Please watch the hypnotic sedative presentation for benzodiazepine mechanism of action. Baclofen is going to bind the GABA B receptor and potentiate it. You also have Valium, otherwise known as diazepine. Diazepine also works as a muscle relaxant. That also targets the GABA A receptor. There's that diazepam. Remember, benzodiazepines have ZE or they have PAM at their ending. Cyclobenzaprine is a serotonin 5-HT2 receptor antagonist. So this receptor will relieve spasm through the action of inhibitory neurons in the brainstem. So essentially, these will go up and they will usually synapse in the brainstem using the medulla oblongata. There are inhibitory neurons there, and they're regulated by serotonin. And if you inhibit these with a serotonin antagonist, you'll have decreased signal down here. That's how cyclobenzaprine works. Diazepam, as I said, works with the GABA A receptor. Dantrolene actually works in the muscle itself. This interferes with, prevents the release of calcium by binding to the ryanodine receptor, blocking endogenous release of calcium, therefore decreasing the ability of the muscle to contract and desensitizing the muscle to motor inputs. Many of the others work in different ways. The thing I want you to see is that these drugs work in very, very different ways, but their output is the same. They decrease the sensitivity of muscles to neural inputs, and they decrease the ability of muscles to constantly contract, therefore promoting muscle relaxation. So some work directly in the muscle, your botulinums, which work at the motor end plate, dantrolene, then others work in the CNS. What are they used for? They're used to relieve the pain and discomfort associated with musculoskeletal injuries. They're used with rest, physical therapy, and other measures. They help to alleviate the pain, the symptoms of spasticity, and they also may be of use in spinal cord injuries or either genetic diseases or other diseases that affect the spinal cord and things that cause contractions, things like muscular dystrophy. Oh, darn, muscular dystrophy, sorry, multiple sclerosis, other diseases like that. Now in children, baclofen is used to relieve the spasticity, say that fast 5 times, associated with cerebral palsy. And then methylcarbamol is a drug of choice for children with tetanus. So remember those 2 drugs, especially for your peds rotations. Methylcarbamol for tetanus, baclofen for cerebral palsy. Now, as we'll see, children should be monitored closely because they're more susceptible to CNS and GI toxicity with these drugs. Other skeletal muscle relaxants have not been shown to be safe in children. So these are really the 3 you can use: methylcarbamol, baclofen, and metaxalone. In adults, when you use these medications, avoid activities that require focus, that require alertness. They shouldn't drive, simply or operate heavy machinery, or make important decisions because of the tendency of these drugs to sedate. And especially in elderly people, they can cause confusion. If you have muscle spasms associated with anxiety, remember our dictum. If you can treat 2 things with 1 drug, do it. Treat them with diazepam, so-called Valium. Also, this is huge. Pregnant lactating women should not take these drugs. Contraindicated. In older adults, use them with great caution. Older adults are more likely to experience adverse side effects of these drugs. Carisoprodol is the drug of choice for older adults and for those with both hepatic and renal impairment, because this is excreted in the GI tract. Contraindications and cautions. Allergies to these drugs have been described. Therefore, look for the signs of allergy. If you get hives, trouble breathing, what have you, withdraw the drug immediately. Skeletal muscle spasms that are caused by rheumatic diseases like rheumatoid arthritis should not be treated with skeletal muscle relaxants. They have no demonstrated benefit in such cases. If there's a history of epilepsy, don't use them. They tend to exacerbate the seizure disorder. There are reports of people using them with people with epilepsy, with certain protocols. That is under the direction and at the discretion of the neurologist or sports physician who uses them. But typically, contraindication, epilepsy. Cardiac function may be depressed, so don't use them in people with cardiac dysfunction. Again, if they're under the care of a cardiologist, and the cardiologist is pretty confident he or she can treat the patient with these drugs, if they have the right monitoring, then they can be treated. But just keep in mind, you're going to be the one who'll have to watch the EKG, will have to watch seizures, so on and so forth. Conditions that are marked by muscle weakness are exacerbated by these drugs. Just don't use them. That's a contraindication. Hepatic or renal dysfunction is also contraindication, again, except for carisoprodol. Baclofen is not indicated for the treatment of spasticity that contributes to the ability to walk or to stand upright. Because if you block those, the person's not going to be able to stand or walk. Now, baclofen is also used off-label to treat addiction. So just keep that in mind. If somebody's getting baclofen for addiction, particularly for alcohol abuse syndrome, then just make sure that you have in mind your protocols for muscle relaxants. Adverse effects include, first and foremost, drowsiness, fatigue, weakness. In elderly patients, confusion is common, not very common at all in younger patients. And then headache and insomnia, albeit these drugs can actually help you sleep, but long-term use can actually bring insomnia. They can cause hypotension and arrhythmias in some patients. Some of these drugs have anticholinergic effects, so they may cause nausea, dry mouth, anorexia, constipation. They can make constipation a lot worse. They can also cause bladder retention. So that's your one here. You can get urinary frequency in some cases, urinary urgency, enuresis, or nocturia or something like that. Chlorzoxazone will turn the urine purplish or orangish or purplish red color. That can really freak people out. Warn them about that. Tizanidine has been associated with liver toxicity and hypotension in some patients. In younger patients, athletes where this is usually used, that's rare. Baclofen will need to be tapered over 1 to 2 weeks to prevent psychosis and hallucinations. That's important particularly in elderly people. Drug interactions. Do not use these with other CNS depressants. Do not use them with alcohol. Use them with opiates with great, great caution, if at all. And other CNS depressants, just don't use them. You'll get marked CNS depression, and that can decrease CNS function in ways that are potentially dangerous. Now let's look at nursing considerations. So first you want to do is assess for the contraindications. Make sure you have a baseline physical assessment. Bilateral grip strength is going to be pretty important. So are reflexes, because these drugs will affect both of those. The other is spasticity evaluation, also very important. You want to get a baseline. And the monitor renal and liver function. That's going to be pretty important to detect adverse effects. Again, you don't have a baseline, you don't have anything to compare it to. So throughout the course of treatment, you want to assess pain, make sure their pain is going down. Then you want to assess any GI and CNS side effects. Those are the most common side effects, GI and CNS side effects. You also want to be aware of disturbed thought processes related to adverse effects. Are you seeing confusion? Are they having hallucinations? Are there's behavior changing? If they're older, they might be at risk for falls. So again, if your patient's a fall risk, put the belt on them, hold on to them, make sure the bed's not too high, walk behind them. Make sure loved ones know that they shouldn't get up on their own, that they shouldn't walk on their own, that they should use a walker or a cane, or a cane. So rest period is very important. These drugs were not meant to be used without rest. Also application of heating pads. My wife makes rice bags. She puts dry rice in them and sews them up. You can put them in the microwave and heat them. Those are quite nice for sore backs or sore hips or something like that. NSAIDs are good, but use NSAIDs with caution because NSAIDs can decrease renal function. Discontinue the drug at any sign of liver or renal anomalies. Also monitor the respiratory status. This is to make sure you're not suppressing respiration. And just help them tolerate the side effects. Provide safety measures, so adequate lighting. Raise side rails on the bed. Make sure, again, the bed's not too high to prevent injuries. And then make sure you promote compliance with the drug and that they don't actually overdose on the drug too. So look for improvement in muscle spasm, relief of pain. That's your first evaluation. Second, monitor those adverse effects. Make sure that the adverse effects are tolerable, that your improvements beat that your payoff is better than your price. Make sure the patient understands the drug. Make sure they know the name, make sure they know what it does, make sure they know what to expect in terms of side effects, and just monitor their compliance and make sure they're not taking too much of this. Some of these drugs, like for example, carisoprodol is addictive. It can cause euphoria. So be careful of some of these. Make sure they're not ODing on them as well. For direct acting skeletal muscle relaxants, it's pretty much the same thing. So dantrolene is used in kids to treat upper motor spasticity. The dose in kids will be by weight. Kids are at increased risk for CNS and GI toxicity, so watch those side effects definitely. By calculating the right dose, you should be able to establish the dose and use that drug safely in children. This is pretty much the same as it was with the last set of drugs. The biggie is hepatotoxicity and dantrolene. If someone has a compromised liver, use either greatly reduced doses of dantrolene or don't use it at all, unless you absolutely need to. Older adults, again, are more likely to experience the side effects. If you have older women who are undergoing hormone replacement therapy, they will have the same risk for hepatotoxicity as with premenopausal women when it comes to the use of dantrolene. So no reason to put women on HRT at an increased risk. So again, allergies. Be careful if the spasticity contributes to movement or standing. Otherwise, they won't be able to stand or sit or walk. Active hepatic disease. Again, pregnancy and lactation. Cardiac disease, just like before. Respiratory depression. History of liver disease. Women who are older than 35 have increased risk of potentially fatal hepatocellular disease. So watch those LTFs for sure. Adverse effects, again, a lot of the same things. Urinary frequency anuresis, crystalline urine with pain or burning urination, particularly with dantrolene. Gastrointestinal irritation, diarrhea, constipation, cramps. Drowsiness, fatigue, confusion, CNS visual disturbances. That's with dantrolene, and also with Botox, particularly if it's injected near the face. Dantrolene is the one you need to watch with liver damage. A one dose of dantrolene won't tend to damage the liver. Botulinum toxins are associated with anaphylactic reactions. So those are characterized by headache, dizziness, muscle pain, paralysis. Headache, dizziness, muscle pain, paralysis. Drug interactions. If you have someone using estrogens, that can increase the incidence of hepatocellular toxicity. And if you use neuromuscular junction blockers, any of these drugs here can block neuromuscular junctions. Don't use them with these drugs. Nursing considerations. So assess for the mentioned contraindications and allergies. Again, if they have rheumatic disease, don't use it. Pregnancy, lactation. That way you just get those out of the way right away. Again, get a baseline. Get a baseline, conduct that thorough physical assessment, get a baseline. Monitor GI, CNS side effects. Make sure, again, the drug is giving you a payoff that's bigger than the price. Also, disturb thought processes. This is not so much a problem with subcutaneous Botox or very, very shallow IM Botox, that doesn't tend to be as much of a problem. It is with dantrolene, potentially. And then risk for injury due to falls, things like that. So if they're on dantrolene, discontinue it for 2 to 4 days to monitor therapeutic effectiveness. The IV sites of dantrolene, if you have potential extravasation, this drug has an alkaline pH. It's really irritating to tissues. So that's if the drug is being given IV. Assess areas that are going to undergo Botox injections, because any area with an active infection will be exacerbated by the injection. Discontinue these drugs at any sign of liver dysfunction. Help the patient deal with side effects. Provide safety measures to prevent injuries, falling risks, so on and so forth, and educate them as to compliance on the drug and not overdoing the drug as well. Albeit that's less of an issue with these drugs. So evaluate. How's the response to therapy? Do you have decreased spasticity, better movement, activities, range of motion, lowered pain? Use the range of motion scale, use the pain scale, evaluate that. Monitor for adverse effects. So diarrhea, liver toxicity, things like that. Evaluate the ability of the patient to talk about the drug, things to watch for, and then monitor their compliance with drug therapy and make sure they're not overdoing it. All right, let's see how well you paid attention. All the following are direct skeletal muscle relaxants except botulinum toxin A, myoblock, dentrium, none of the above. Well, myoblock is a trade name of botulinum toxin type B. Dentrium's a trade name of dantrolene. All three of those are direct acting skeletal muscle relaxants. So the answer is D. Which of the following is a priority nursing intervention for children receiving muscle relaxants? A, assess bowel sounds and activity. B, provide skin care. C, administer drug with food. D, both A and B. Your answer to this one is A, because kids are at higher risk for GI and CNS side effects. These are CNS and GI side effects. That's what you assess. Question 3. What is a centrally acting muscle relaxant of choice for children with tetanus? A, botulinum toxin B, B, dentrium, C, baclofen, and D, methocarbamol. The answer is D. Baclofen is indicated for release of spasticity in children with cerebral palsy. For tetanus, methocarbamol is used. Dantrolene is for upper torso spasm, not tetanus, and botulinum toxin B is contraindicated in kids. Question 4. How long should baclofen be tapered to prevent development of psychoses and hallucinations? 12 to 21 days, 1 to 10 days, 7 to 14 days, 7 to 21 days. The answer is C, 7 to 14 days. Question 5. A patient who has had a dose of botulinum toxin type A complained of headache and dizziness. What is the most appropriate nursing response? A, provide comforting measures. B, institute safety measures. C, assess for possible anaphylactic reactions. Or D, both A and B. Headache, and dizziness. Those are signs of an anaphylactic reaction, so the answer is C. So botulinum toxins are associated with anaphylactic reactions characterized by headache, dizziness, muscle pain, and paralysis. So the answer is C. Okay. Well done, nurses. I will see you next time.